will be better equipped for your NEET PG, whatever exam you're going to have at the end of internship or at the beginning of internship, wherever is that exam going to happen. So I hope all of you have read through the notes, my notes that I have given you in the class. You would have used them on our DAMS Alpha app, which is the best app with exclusively for second MBBS. We are having classes exclusively for second MBBS in our app, and I'm sure, I hope all of you have used those videos, right? Hi, good evening, everyone. So, yeah, can you give me a thumbs up in the chat box? Just a minute. Just a minute, guys. There is some issue with my display. Okay, sorry. Yeah, so let's start with question 1 now. Yes, good evening, everyone. Good evening. So I hope all of you are able to see the questions here. Yeah, and you can be using it. I want it to be interactive. I want you to be using the chat box. If you are on the app, on the DAM Self app, you can use it on the app itself, or if you are watching this through YouTube, you can always use the chat box on the YouTube as well. Okay. Yeah, so let us look at question number 1 now. Yes, guys, what is question number 1? Let me start with the question. What is the question? Says a patient is being transfused blood. Okay, 1 unit of packed RBC. So he's given blood here. He is getting blood here. Okay, now, so 15 minutes into transfusion. So what you are seeing, 15 minutes, just 15 minutes after starting transfusion, the patient develops fever and chills. Anybody? What is fever and chills after blood transfusion? Guys, please tell me. Yes, yes. Let me look at chat box now. Yeah, please tell me what is fever and chills after a blood transfusion. What do you suspect? Fever and chills. Yeah. So I'm just looking for your answers on the chat box. Fever and chills after blood transfusion. What is your diagnosis? Okay, my diagnosis here is FNHTR. What is FNHTR? Febrile non-hemolytic transfusion reaction. FNHTR. Febrile non-hemolytic transfusion reaction. Febrile non-hemolytic transfusion reaction. Okay, what is the question asked here? Let us talk about question. What is the question? Physician immediately stops the transfusion. Yes, correct. So that should be the treatment. By the way, any blood transfusion reaction, what should you be doing? Immediately stop the blood transfusion. Now, once I stop the blood transfusion, then what do I do? Once I stop the blood transfusion, which of the following is true? That is the question asked. So they are not asking me what should I be doing, which is true has been asked, and it is a multiple true false type of question, guys. So what is this multiple true false type of question? So there are 5 options given, 1, 2, 3, 4 and 5, and examiner is asking what is correct. 2, 3 are correct, 2, 3, 4, 3, 5, 1, 3, 5. So that is what is your multiple true false. Let us look at true about this. Cross matching would have prevented this. Is it a true statement, guys? Please tell me now. Is it a true statement? Cross matching would have prevented? No. Answer is this is false. Cross matching would have prevented hemolytic transfusion reaction. This is a non-hemolytic transfusion reaction, isn't it? So cross matching wouldn't have prevented. What would have prevented, by the way? If somebody asks me, FNHTR could be prevented by leukodepleted RBCs, isn't it? Leukodepleted RBCs could be leukodepleted RBCs, or leukodepleted blood will be preventing this. So prevention will be done by this leukodepleted RBC. Okay, how do you do leukodepletion? If you studied, if you remember, yeah, leukodepletion we studied by 3 mechanisms. One, by removal of buffy coat. If you remove buffy coat, WBCs will be gone, isn't it? Second, another way of leukodepletion, use of WBC filter. And the third way is irradiation. You expose the blood to gamma rays and you will kill the WBCs there, right? Yeah, that is how you do. Anti-HLA antibodies from donor have caused this. False. It is not from the donor. Mechanism of FNHTR. What is the mechanism of FNHTR? Mechanism is anti-HLA antibodies. Anti-HLA antibodies from patient. From the patient kill WBCs of the donor. So WBCs from the donor. Whatever WBCs do come from the donor, anti-HLA antibodies will kill them. And once the antibodies kill them, there will be release of cytokines from the WBCs. cytokine release will be there, and once the cytokine release, this will lead to fever, isn't it? So it is not an infectious cause, it is an cytokines that will be released from the donor WBC, killing of donor WBC. Antibiotics are helpful. That is also false statement. Antibiotics will not help us. Why? Because it is not an infectious cause, isn't it? Antibiotics are helpful. That is false. Saline washing of RBC could have prevented this. Saline washing, false. Why? Saline washing would have prevented what? Oh, sorry. Third option, look at the third option. Antibiotics are not helpful. Okay, that is a okay. I misread it, guys. Sorry. Antibiotics are not helpful. That is a true statement. Antibiotics are not helpful is true. We don't give antibiotics because this is not an infectious cause, isn't it? So 3 is true. Saline washed RBCs would have prevented this. No, saline washing would have prevented anaphylaxis and allergy. We studied this also in blood banking. Anaphylaxis and allergy would have been prevented by saline washing. Anti-HLA antibodies from the patient are the cause. Yes, that is a true statement. So 3 and 5 are true. 3 and 5, option C. Option C, that is true here. 3 and 5 are true. Right? Yes. Next question. Let us look at next question now. So I hope all of you understood this now, concept behind the question. Question was about your febrile non-hemolytic transfusion reaction, which is a type 2 hypersensitivity reaction. Isn't it? It's a type 2 hypersensitivity reaction. Next question. Next question, let us look at this. Which of the following is correct order of changes in iron deficiency anemia? So examiner is asking what are the correct order of changes. So this is a new pattern of question that are coming nowadays in exam. The pattern order they are asking you. So which of the following is the correct order of changes in IDA? In IDA, the first thing to happen is, if you remember, what is it? Decrease in serum ferritin, if that is given. Yeah, serum ferritin, this will be the first thing to happen. That is number 2 will be 1. Okay, all of them are having number 2 only. Okay, decrease serum ferritin. Then after that, increase in TIBC will happen. That is your second thing that will happen. Increase in TIBC. If you remember, once you stop eating iron, your stores will start depleting. Liver ferritin will deplete, and then what? Serum ferritin depletes, and you are releasing the iron from the liver. To bind this iron, you are producing more transferrin. That's why your TIBC is increasing. Then the third one, transferrin saturation will decrease. The last thing to happen is decrease in serum iron. Decrease in serum iron. So answer is, it will be 2, 3, 4 and 1. 2, 3, 4, 1. Option B. That is the correct answer. So 2, 3, 4, 1 here. So new pattern of question that are coming in exam, multiple true false type of question, and another is a chronology question. So they will ask you what is the correct chronology, that like we discussed here. Okay. Yes. This is your iron. Okay. So decrease in serum ferritin, if you remember, we studied this is the most sensitive test. Most sensitive and also the earliest test for IDA. Most sensitive and earliest test for iron deficiency anemia. So this can be asked even in your Viva as well. So please expect this. Earliest and the most sensitive test for iron deficiency anemia is what? Serum ferritin. Right? Yes. Next, let us look at the third question now. Third question, which of the following correctly depicts oxygen dissociation curve in a patient after blood transfusion? So what will happen once you transfuse blood? Very, very important is, whenever you are in blood, yes, in blood bank, what will happen? In the blood bank, if you remember, we discussed this also. In the blood bank, if you storage will be done at what? Storage is done at 2 to 6 degrees Celsius, that is refrigerator. Here, there will be decreased enzymatic activity of the RBC. So, enzymatic activity is reduced, so everything will be reduced. This will also lead to decrease in 2,3-DPG in the RBC. Anybody? If 2,3-DPG decreases, what will happen now? 2,3-DPG or BPG will be decreased. This leads to O2 curve shifts towards what? O2 dissociation curve shifts to left, isn't it? It will shift to the left. That is a concept here. So which is shifting towards the left here. So look at this, the leftmost, that is your option A. That is what is going to happen here. This curve, of course, D is wrong. Straight curves will not be there. Option A is the correct answer. Shifted to left will be there. So very important, DPG will be very low DPG in ACD blood. What is ACD? Acid citrate dextrose blood. Whereas slightly more, okay, so it will be slightly more in CPD blood. What is CPD? Citrate phosphate dextrose blood. Addition of phosphate itself increases the DPG in the RBC, and that is why we are adding phosphate to the preservative, right? Yes. So this is the gist of the question. Question asked is what is happening. So in blood banks during storage there will be what? Decrease in DPG happening. So in this, if at all specifically I want to know, probably A would be the leftmost curve, isn't it? So this would be a ACD, B would be a CPD, because B is having slightly more what? DPG. That is why it will be slightly towards the right, and the best one will be C. That probably would be the normal blood here, isn't it? Yes. Next, question number 4. Role of, it is a one-liner question, role of glucose in CPDA SGM as a blood preservative is. So what is the role of glucose? Nutrition to the RBC? No, nutrition is provided by dextrose. Nutrition is provided by dextrose. What is dextrose and glucose difference? L-glucose. Levo-rotated molecule is your L-glucose. We are adding L-glucose and D-glucose. What is D-glucose? Dextro-rotated molecule is your D-glucose. Nutrition is provided by D-glucose. Increase DPG? No, this will be done by phosphate. If you remember, we just discussed that phosphate will be leading to increase in DPG. Increase in shelf life? No, glucose doesn't increase shelf life. What will increase in shelf life? Adenine will increase. Okay, sorry. Increase in shelf life is the correct answer. Glucose will increase the shelf life. ATPs will be increased because of adenine. So increased shelf life will be by adenine and also SGM. What are SGM stand for? Saline glucose and mannitol. If you remember this also, saline glucose mannitol. We add saline glucose mannitol. What do saline glucose mannitol do? They are osmotic agent, and because they are osmotic agent, they do not allow the RBCs to swell. That is what is happening. Saline glucose and mannitol. That is your CPDA SGM. Adenine also increases shelf life by increase in ATP. So yes, increase ATP increases, that is why shelf life will also increase, right? SGM, saline glucose and mannitol, they will be what? Saline glucose and mannitol, all of them will be increasing your, yes, saline glucose and mannitol, all of them will increase the shelf life by preventing swelling of the RBC, isn't it? By preventing swelling of RBC. Okay. Okay, next. Let us look at next question now. Last line. Okay, not last line. We'll start looking at the question only. What is the question says? In a laboratory test, patient serum was mixed with reagent RBC, to which further anti-human globulin was added. Which of the following test is described in this question? So what is the question asked here? Patient serum was mixed with, so serum is mixed plus what? Reagent RBC plus anti-human globulin, AHG we can call it, anti-human globulin. This is nothing but your Coombs serum. This is your Coombs serum. So what test has been done? This is a Coombs test, and we are taking patient's what? Serum. That is why this is an indirect Coombs test, ICT. Option C, indirect Coombs test is done, described here. That is your indirect Coombs test here. Next question. Okay, look at this question now. What is this question says? A patient with severe anemia is being transfused blood. Okay, patient is having anemia, blood transfusion is being done. When transfusion is just about to finish, the patient complains of tightness in the chest. Okay, he is having complaints of tightness. Pulse is 98, slightly elevated, I guess. Baseline we do not know. Assuming it was normal, then it is elevated. Respiratory rate slightly elevated, 26 definitely elevated. BP is 114, 690. BP is also increased. Increased BP, increase in respiratory rate. You stop the blood transfusion, started the patient on inhalational oxygen. what additional treatment is required has to be given into the patient. Okay, very important. If patient is having dyspnea is there, of course, tightness of the chest is there, BP is increased. So dyspnea is increased, dyspnea is there, it could be a category 2 reaction. In category 2, we just give bronchodilators, but it is already inhalational oxygen is given. That means this is category 3 reaction, isn't it? So category 3 reaction could be a tacho or a trally. So now tell me, this is tacho or a trally? Dyspnea will be tacho versus trally. So is it tacho or a trally, guys? Please tell me now, tacho or trally. How do I differentiate tacho from trally? Yeah, please tell me, chat box. Please use your chat box. Tacho, trally, how are they differentiated? Yes, tacho versus trally. How do you differentiate? Tacho versus trally. BP is the most important. Increased BP will be tacho. In trally, either normal or decrease in BP will be there, right? So answer to this question, this is your BP is high, so tacho is there. Tacho for further treatment will be diuretics. We will be giving diuretics further for tacho. Right, for trally we would have given steroids and fluids, but for tacho we will be giving diuretics here. Next question. Okay. A patient presents with chronic diarrhea. Okay, there is a diarrhea and recently diagnosed of celiac disease. Okay, he is having celiac disease. So diarrhea with celiac disease. Okay, celiac disease is causing diarrhea. What is celiac disease? Gluten sensitive enteropathy, in which there is sensitivity to gluten containing diet like wheat, where the villus of the intestine undergo atrophy, and because of that absorption is not happening. Intestine including both duodenum and jejunum will undergo atrophy. The peripheral blood examination is as follows. Which of the following deficiency has led to such a manifestation? Iron, folate, B12 and gliadin. Okay, what is a peripheral blood smear showing? Look at this peripheral blood smear. What I am seeing here, this is your, okay, these are macrocytes. I am definitely seeing macrocytes that are there. What are macrocytes? RBCs are larger than the lymphocyte. You are able to see this is a lymphocyte comparing with the lymphocyte. So look at this. This is your lymphocyte here, and these RBCs are what? Larger macrocytes. And this is your another one, hyper-segmented neutrophil. So if there are hyper-segmented neutrophils that are seen and macrocytes are there, neutrophils. So what is your diagnosis? The diagnosis is megaloblastic anemia. What are the causes of megaloblastic anemia? Megaloblastic could be due to either B12 deficiency or folate deficiency, if you remember. Yeah, folate deficiency, B12. So patient is having a celiac disease. Celiac disease is more likely to result in folate deficiency because folate absorption happens in jejunum, whereas B12 deficiency, B12 absorption happens in the terminal ileum. In celiac, there is no involvement of ileum at all, isn't it? It is involving the proximal intestine, right? And that is why answer is folate deficiency. That is the correct answer. Option B, folic acid deficiency. Next question. Question number 8. Okay, during preservation, which of the following coagulation factor decreases the earliest? Okay, during preservation of the blood, which factor decreases earliest? This is asking about, yes, which are heat labile factors. Basically, the question is which are heat labile factors? Are factor 8 and factor 5. Two important factors are heat labile. So the earliest factor to deplete will be factor 8. Do not confuse this with half-life of factor. Half-life of factor shortest is what? Factor 7. So first one to deplete in the blood will be what? Factor 8 is the first one to deplete in the blood. Okay. Followed by factor 5. And that is why if you remember, so while separation of FFP, we say we have to separate as soon as possible within 8 hours. So if you separate it beyond 8 hours, factor 8 would have significantly reduced. And that is why you will not get a cryoprecipitate and FFP will not contain factors. Next, question 9. Let us look at this question 9 now. What is this? A 2-year child of a Sindhi couple. Importance of Sindhi couple. Okay, familial, if we are talking inherited condition, then thalassemias are common in Sindhis and in Punjabis, has severe anemia, prominent jaws and splenomegaly. Now I can suspect severe anemia, prominent jaws, splenomegaly more in favor of thalassemia. Peripheral blood smear shows microcytic hypochromic with numerous target and teardrop cell. Okay, so definitely now what is my diagnosis? Target teardrop cell, definitely diagnosis is thalassemia. So question is, splenomegaly in this child is due to what? Okay, examiner is asking you, why is the splenomegaly happening? Extramedullary hematopoiesis, extravascular hemolysis, portal vein congestion, ischemia to spleen. There is no ischemia to the spleen. In fact, that will happen in sickle, and that will not lead to splenomegaly. That will lead to autosplenectomy. Portal venous congestion, nothing to do with portal venous congestion will be obstruction to the portal vein. There will be congestion happening, and that will lead to CVC of spleen. Okay, that is also not. Extravascular hemolysis, extramedullary hematopoiesis, predominantly splenomegaly is due to extramedullary hematopoiesis. Important site of hemolysis in thalassemia. We discussed this also in the class. Site of hemolysis in thalassemia predominantly is bone marrow, not what? Spleen. Predominantly it is bone marrow where it is ineffective erythropoiesis that is happening, isn't it? Ineffective erythropoiesis. Do expect this also for Viva. In exam, they will ask you splenomegaly. Viva question especially splenomegaly in thalassemia, or they will ask you where is the site of lysis happening in thalassemia. Predominant site of lysis in thalassemia is ineffective erythropoiesis in the bone marrow, isn't it? Yes. Next, question number 10. Question number 10. Okay, which of the following persons cannot be donating blood? So who cannot donate blood? Okay, basically the concept of blood donation is we want the donor to be healthy so that he doesn't have any disease and it doesn't get transmitted to the patient, and also he should be so healthy that if he, by donating, his health should not get compromised, isn't it? That is the principle of blood donation here. Okay, homosexuals cannot donate blood. Why they cannot donate? Which of the following cannot donate, right? So yes, they cannot donate. This is a true statement then. So yeah, this is true. Homosexual, because especially the more male homosexuals cannot donate, because in male homosexuality HIV incidence is very high. So HIV is very high in male homosexuals. That is why we do not allow them to donate. Next, history of vaccination 3 months back. Answer is no, they can donate blood. So this is a false. So if you had a vaccination in the last 15 days, you can't donate. Specifically vaccination, if they are asking you a live vaccine, which we usually don't take. In an adult, we don't take a live vaccine. The only live vaccine that we take is OPV, which is in childhood, and in which children are not eligible to donate blood. So in an adult, if we are talking, because donation age minimum is 18 years, right? So 3 months back, no, that is false. 15 days back. Vaccination for, he should not have taken any vaccination for 15 days. History of surgery 3 months back. Yes, true, he cannot donate. History of surgery, specifically, if there is a major surgery for 1 year, he cannot donate blood. And for minor surgery for 6 months, you cannot donate blood. So major surgery 1 year, minor surgery 6 months. Diabetic person, diabetic people can donate blood. If they are controlled, we can donate blood. They can donate blood. We can take the blood from them. Diabetic cannot donate blood. No, false. Diabetic can donate blood. Weight less than 60 kgs. Yes, false again. What is the minimum weight? Minimum weight is 45 kg. Minimum weight is 45 kg. More than 45, it should be the weight. So this is your, and age, maximum age is 65 years, right? Okay, who cannot donate blood? That is a question asked. Who cannot donate blood? Homosexual cannot donate blood, and surgery 3 months back. 1 and 3, only 2 of them cannot donate blood here. Option A. Okay. Next question. Next question. A routine CBC of a 16-week pregnant woman shows hemoglobin 11. Okay, pregnancy hemoglobin 11, MCH 20 to MCV 60. Definitely microcytic RBC, microcytic hypochromic. So what are your DDs for microcytic hypochromic here? Microcytic hypochromic, my DDs will be Sita. Sideroblastic iron deficiency, thalassemia, and anemia of chronic disease, isn't it? RBC count 5 million. This is the keyword for me now. RBC count is 5. Look, RBC count is very high as compared to the hemoglobin. Patient's hemoglobin is only what, 11. So RBC count is higher. RBC count is high for the hemoglobin. How much is hemoglobin? Hemoglobin is only 11, whereas RBC is what? 5 million. So what do I mean by this condition now? So whenever I am having like this, RBC count is higher as compared to your what? Hemoglobin, start suspecting. So I'm suspecting thal minor here. So I'm suspecting thalassemia minor in the patient. How do I confirm on CBC only? Okay, red T count is 2%. She's taking 60 milligram of oral iron and folic acid daily. What is the next line of management they are asking? What should I be doing? So if I'm suspecting thal minor, I have to first confirm, first on CBC only. Let me try to do one more. If it is thal minor, we have to calculate one more. What is that? Menzer index we discussed. What is Menzer index? Menzer index is ratio of MCV to RBC count, isn't it? So what is the value of MCV here? MCV is 60 divided by RBC count of 5 million. Value is 12, less than 13. So Menzer index is less than 13, which is less than 13 is again suggestive of thal minor. So I am definitely suspecting thal minor. I have to confirm whether is she thal minor, because she's already pregnant. I want to check if she is thal minor, then I have to screen husband also. If he is also thal minor, then fetus has to be screened, isn't it? That should be my approach here. So what do I do? Next line of investigation would be HPLC, option C. On HPLC, I want to measure hemoglobin A2 levels. HbA2 levels have to be measured in this patient, right? HPLC. Next, question 12. Let us look at this question now. What is it? A newborn is having excessive umbilical cord bleeding. Okay, what are the DDs for umbilical cord bleeding in a newborn? DDs for umbilical cord bleeding in a newborn are factor 13 deficiency and vitamin K deficiency, severe platelet disorders. Severe platelet disorders also can be causing this, like severe thrombocytopenia or aggregation disorders like Glanzmann thrombasthenia can be causing. Despite okay, next line says, despite IV vitamin K injection, the bleeding is not stopping. So it is unlikely to be vitamin K deficiency, isn't it? So you decide to transfuse an FFP. Okay, diagnosis. Okay, you transfuse an FFP. Slide agglutination test from heel prick of the baby is as follows. Okay, they are not asking you what is the diagnosis here. Anyway, so we already have discussed what are the DDs here. Anyway, they are not asking you diagnosis. They are asking you the blood group has been given. So this is the heel prick of the baby and this is the blood group. Clumping is not happening with A. No clumping. So no clumping with A and no clumping with B also. What do you mean by what is the blood group now? No clumping with A, no clumping with B, meaning patient's blood group. What is the blood group of the patient here? Patient is O blood group. So patient is O. So question asked is, which of the following FFP can be safely transfused to this newborn? So which FFP can be given? O, if you remember, is universal recipient for FFP. He's a universal donor for blood, but he's universal recipient for FFP. That is why any FFP can be given. Any FFP can be given. Okay, any FFP. Why? Why the blood group is O here? No clumping with A and no clumping with B. So that means the patient doesn't have neither A antigen nor has what? B antigen. That is why blood group is O. Question 13. Absorption of iron happens in, yes, where does absorption of iron happen? In the duodenum, proximal duodenum. In jejunum, what gets absorbed? Folic acid. In ileum, what gets absorbed? Vitamin B12 gets absorbed. Stomach is required for absorption of iron as well as vitamin B12. So stomach absorption doesn't happen, but however it is required for iron because acidic pH is required, for B12 because of intrinsic factor, isn't it? You require intrinsic factor in a B12. Next. Question 14. Vitamin B12 helps in conversion of. So what conversion does it help in? THF to methyl THF, methionine to homocysteine, Propionyl-CoA to methyl-malonyl-CoA, methyl-malonyl-CoA to succinyl-CoA. So what all it will help? THF to methyl THF? No. It will help in conversion of methyl THF to THF if you want to know. Methionine to homocysteine? Yes. Methionine to homocysteine? No. It will convert homocysteine to methionine. So this is also wrong. So it will convert methyl THF to THF, and at the same time, so your methyl THF which is there in the plasma, methyl THF is there in the plasma, it gets converted to THF, and this conversion requires homocysteine gets converted to what? Methionine. Methionine. And this will be done by vitamin B12. Homocysteine to methionine is done by B12. Question is methionine to homocysteine? No. Propionyl-CoA to methyl-malonyl-CoA, methyl-malonyl-CoA to succinyl-CoA. Answer is methyl-malonyl-CoA to succinyl-CoA. Only option 4. Only 4. That is the role of vitamin B12. Next question. Okay. A patient presents with calf pain. Okay. He is having calf pain. Imaging shows thrombus in the vein. Okay. In the calf, if there is a vein, what is your diagnosis? Diagnosis is deep vein thrombosis. Deep vein thrombosis, or we short form we call it as DVT, isn't it? That is your diagnosis. Okay. CBC shows hemoglobin of 10. Okay. Hemoglobin is less. Platelet count less. Okay. DVT plus, what else is there? DVT plus decrease in platelet, decrease in hemoglobin also, and TLC is 3000. That is okay, low normal I would say. DLC neutrophil 60, lymphos 20, monos 10, eosinophil 5. Leukocyte alkaline phosphatase is reduced. Lab score is reduced. All these are in favor of urine dipstick for hemoglobin is positive, plus hemoglobinuria. There is also hemoglobinuria. So what is this now? What is your diagnosis? This is a classical thrombosis, thrombocytopenia, and hemoglobinuria is a classical triad of PNH. And lab score is decreased. That is also in favor of PNH. So my diagnosis here, paroxysmal nocturnal hemoglobinuria. Which of the following investigation will diagnose the condition? Answer, flow cytometry. What should I demonstrate on flow cytometry? CD59 should be negative, and CD55 also should be negative. 55, 59 should be negative here, right? That should be the investigation here, flow cytometry. Fish for JAK2 analysis, that will be done for polycythemia vera. Fish for Philadelphia for CML, bone marrow aspirate for blast will be for AMS. Next, question number 16. Question number 16, hemoglobin C is due to, what is hemoglobin C? Hemoglobin C is a missense mutation in 6th amino acid. That is correct. In 6th amino acid, it is glutamate to valine. No, this will be your hemoglobin S. Missense mutation in 6th amino acid leading glutamate to lysine. That is the correct answer. In 26th amino acid, glutamate to lysine. That is your hemoglobin E. Hemoglobin C. Right? Yes. So these are your different variant hemoglobin. 121st amino acid glutamate to glycine, that will be hemoglobin D Punjab, or yes, that will be a rare one. So answer to this question, option B. Next, question number 17. Let us look at question 17. A 32-year G3P2 lady. So what is G3P2? Gravida 3 para 2 presents with easy fatigue. Okay, she is having fatigue. Peripheral blood examination shows hemoglobin 8. Now we can understand. So patient is definitely having anemia. Hemoglobin is 8, anemia. RBC count 3.5 million. So decrease RBC. I'm not thinking of what? So decrease in RBC. I'm not thinking of thal minor, isn't it? Yeah, decrease RBC. Hematocrit 24.5, retic count 2%. Peripheral blood smear is as shown in the image. Which of the following is the most likely cause of anemia in her? Okay, peripheral blood smear has been given to us. What is the peripheral blood smear? Look at this. What is this? This is the lymphocyte. Now, what am I saying? Definitely RBCs are what? Smaller. I can see microcytic. How do I know microcytic? Compare the RBC with the size of the nucleus of the lymphocyte. So look at this. Let me try to show you. This is the nucleus of the lymphocyte. RBCs definitely look what? Smaller than that. That's why microcytic. Central pallor is more than 1/3. That's why I will call them hypochromic also. So they are microcytic. hypochromic RBC. And also look at this, what am I seeing? These are your pencil shaped RBC. Pencil shaped RBC. This is more than enough for me for diagnosis of iron deficiency anemia. So most likely cause would be iron deficiency anemia. Option A. Hemodilution, no, hemodilution would have led to normocytic anemia. Normocytic anemia. B12 would have led to macrocytic anemia. Hemolytic anemia, that is not the case here, right? Next. Okay, this is a more practical oriented question now. This can come as a MCQ in exam and of course in your Viva as well. A first year medical graduate is doing his own RBC count in a Newbar's chamber. He draws blood up to 0.5, diluent up to 11 and counts the RBC in the red boxes mentioned as under. So, which of the following is correct inference to be drawn? Okay, very important. He draws blood up to 0.5. Yes, that is correct. Diluent up to 11 marking. This is a wrong because he has picked up what? WBC pipette. RBC pipette will have maximum marking of 101. Here he has picked up what? 11. That means he has picked up a wrong pipette. That was your WBC pipette. And then he has counted the RBC in the red boxes. Yeah, that is a correct counting. So counting has been correct, but the dilution is in a wrong what do you call pipette. Counting is correct, dilution is wrong. That is the correct answer. Counting is correct, but the dilution is wrong, right? Next question. Okay, a patient presents with easy fatigue. Again, easy fatigue, again you are thinking of anemia. Reduced hemoglobin already given, that means anemia pakka for last 4 months. So patient is having anemia for the 4 months. She has self-medicated with iron preparation. So she already has taken iron preparation with no benefits. So she doesn't have. So she is anemia plus non-responder. I would say non-responder to oral iron now. Non-responder to oral iron. So it could be something else other than iron deficiency, or there could be malabsorption also, both non-responder. Peripheral blood examination shows hemoglobin 7.7. RBC count 3.5 million. Okay, RBC count is low. RBC hemoglobin is also low. MCH 22, MCV 30. Okay, MCH is 32. MCV 32 unlikely. 62 should have been the answer anyway. MCH is 22. Definitely microcytic hypochromic anemia. Again, microcytic hypochromic anemia not responding to oral iron. Could be Sita iron. Only thing is it will be not a iron deficiency. It will be a malabsorption of oral iron if it is there. Iron profile showed serum iron is 25. Serum iron is low already. Normal value will be 50 to 150. Ferritin is also 15. That is also low. So low serum ferritin, low serum iron. So my diagnosis is IDA. And because she is not responder, I would call malabsorption. IDA due to what? Malabsorption. Why? Because she is not responding to oral iron. So what should be the next line of management? Bone marrow aspirate, continue oral iron, major CRP, injectable iron. Answer should be what? Injectable iron. Why? Non-responder. Patient is a non-responder here, isn't it? And patient is having iron deficiency. Next question. Okay, sorry. The same question has got repeated here, 19 and 20. So let us look at the next question, 21st question. Blood product not obtained by centrifugation. So blood product which is not obtained by centrifugation is your cryoprecipitate. No, for cryo you have to do centrifuge. Plasma, RBC, serum albumin. Answer is serum. Anything serum albumin, you do not want to what centrifuge at all. RBCs, no, you have to what? FFP also you have to centrifuge. Platelet, FFP, cryoprecipitate, packed RBC, granulocyte concentrate. All of them you have to centrifuge, isn't it? Answer will be what? Albumin. Next question, 22. Shelf life of cryoprecipitate is, what is the shelf life of cryoprecipitate? Cryoprecipitate shelf life is 1 year. That is the correct answer. Option C. Shelf life of RBC will be 42 days. Shelf life of platelet will be 5 days. With agitation, it will be 5 days. Platelet without agitation will be only 1 day. With agitation, platelet shelf life will be 5 days. Without agitation, only 1 day. Next question. In a thalassaemic patient, which virus would attack the stem cells of the bone marrow and cause aplasia? So answer is, which virus causes aplasia? Parvovirus B19, which causes aplastic anemia, pure red cell aplasia. So important, this will go and infect the stem cells of the RBC, erythroid stem cells, and kill the death of erythroid stem cells, and that will lead to, so that is your parvovirus. Parvovirus lead to clinically what? Slapped cheek appearance. Important, clinically you see slapped cheek appearance, parvovirus, and usually it will cause a transient aplasia. So treatment would be, just have to um, uh, symptomatic treatment, no need of bone marrow transplantation, etc. here. Next, assertion reasoning type of question. So in assertion reasoning, always I start with reasoning. Why? Because I need to know whether R is true or false, because without that it is very tough for me to answer assertion reasoning type. Reasoning, and actually what they are expecting you R to be independently true, isn't it? So when you want to independently be true, then if you read assertion, then you read reason, then you'll have a problem, because you will have carry that assertion in your mind. So start with reason. Humans can produce antibodies only to ABO antigen. Is it a true statement or a false statement? I want to know. Humans can produce antibodies only to ABO. This would be a false. Why? Because, okay, naturally occurring antibodies are only to ABO, but humans can produce only to ABO will be false. He can produce, humans can produce antibodies to any antigen, but only thing is naturally occurring are only to ABO. So R is false. Look at this. The moment R is false, then either this or this. I am ruling out 3 options here. So now I want to know A is true or A is false. ABO is the most important blood of all the blood groups. Answer is yes, that is true statement. So A is true and R is a false here. So ABO is most important. What is the correct explanation? Why ABO is the most important? Because humans have naturally occurring antibodies only to ABO antigen. So the word it is written here is can produce antibodies only to ABO. That is false. Naturally occurring antibodies are only to what? ABO. Right? Next. A patient's CBC is as follows: hemoglobin 10, hematocrit 30, retic count 9%. What is his reticulocyte production index? So what is reticulocyte production index? RPI. RPI is equal to CRC divided by maturation time. CRC divided by maturation time. So what is maturation time? Maturation time will be dependent on hematocrit. Hematocrit and maturation time. Hematocrit more than 40, maturation time will be 1. 30 to 40, it will be 1.5. 20 to 30, it will be 2. And less than 20, hematocrit, it will be 2.5. So in this, hematocrit is 30. So answer will be hematocrit is 30. Then it will be what? 1.5. That is your, what do you call, maturation index. But what is CRC? Now let us calculate CRC. CRC is equal to patient's hemoglobin into the retic count divided by 15. What is the patient's hemoglobin? 10 into retic count. What is retic count given? 9% divided by 15. So if I divide, 3 3s are 9, 3 5s are 15, 5 2s are 10. So CRC is 6. CRC is 6, then RPI will be what? RPI is equal to CRC 6 divided by maturation time is how much? 1.5. So what is the value? 1.5 into 4. That is the correct answer. Option B, 4. Option B, 4. Right? Yes. So this is your RPI and CRC. So guys, I hope all of you enjoyed the questions and you understood how to approach the questions, right? So if any doubts, if you still are in doubts, please, ask your doubts in the chat box here. Yeah, please, you can use the chat box to ask your doubts. I want to keep it as much interactive as possible. And if you are still confused, please go back to your videos from DAMS Alpha app. DAMS is the only place where you end up getting in-depth study, but it will be a concise study, whatever is required actually for your actual exams. Any doubts? Okay, so guys, I don't see any doubts, so I'll be logging off now. Good night, everybody. See you in the next session.